Good afternoon. I'm Johanu Botha, Operations Lead for the Vaccine Implementation Task Force, joined by Dr. Josh Reimer, Medical Lead. There have been a number of really important milestones this week and some new initiatives that will improve vaccine access for more people. I'm incredibly honored to share these updates with you on behalf of the people on the task force who are working to make it all happen. The Selkirk Supersite opened on Monday this week, which is an important addition to our network of supersites. Our expansion at the Winnipeg Supersite at the RBC Convention Centre is also ready to launch, once we have enough vaccine for that to be needed. I can also confirm that the Supersite in Morden, located at the Access Event Centre, will open on March 22nd. Eligible people can begin calling today to make appointments at that Morden location. And we are also currently taking appointments for all of our Supersite locations. This all connects into how we build into our daily maximum capacity. I have talked about this before. This is how we measure how many doses of vaccine we could give in a day if supply wasn't an issue, if we could just turn on the tap. Our goal is to be able to give 1.5 million doses of vaccine by the end of the second quarter beginning on April 1st and lasting for 3 months. To achieve that, our daily maximum capacity has to be 20,000 doses a day. As of today, with the sites and locations we can open today, we are built for 18,973 doses a day. This includes our super sites, the distributed model with doctors and pharmacists, focused immunization teams, and pop-up clinics. We are not done yet. This figure does not yet include the Morden Supersite or any other location that isn't ready to open today. I look forward to updating you when we've reached our maximum capacity of 20,000 doses a day, along with what that means for our immunization campaign and for you specifically. However, at this time, for now, supply is still a critical limiting factor. We're built for nearly 19,000 doses a day at this time. But based on the amount of vaccine we are expecting to get from the federal government this month, we're projecting giving approximately 4,300 doses a day through the super sites, the pop-ups that are coming up, and focused immunization teams over the next 28 days, yielding approximately 120,000 over that time period. Now, of course, there are more doses than that coming into the province over that time that our First Nation partners use to administer vaccine on First Nation communities. With vaccine supply stabilizing and expected to increase in the weeks ahead, we are able to, starting next week, introduce more pop-up immunization clinics in rural and northern Manitoba in the weeks ahead. Earlier today, in the vaccine bulletin, we set out our first 2-week schedule of where we will be operating these pop-up sites. By the end of this month, starting on March 18th, we will have visited Morris, Portage-la Prairie, Sprague, Pilots Mound, Niverville, Gimli, Beausejour, Pine Falls, Ashern, Toulon, Ericsdale, St. Laurent, Penowa, Dauphin, Swan River, Flin Flon, and the Pas. So, if you live in or near those communities and you meet the provincial eligibility criteria, you can book your appointment starting tomorrow morning when the call center opens at 6 a.m. And that brings me to the final item I want to speak about before turning things over to Dr. Reimer. The first shipment of the AstraZeneca Covishield vaccine arrived in Manitoba yesterday, a total of 18,000 doses. As we've spoken about before, this vaccine will be administered through what we're calling our distributed model, so working with our medical clinic partners and pharmacists. We've allocated these first doses through a pilot project model to locations throughout the province. Now that the vaccine has arrived, we are shipping that vaccine out to clinics and pharmacists so that they can begin giving the vaccine as soon as possible. It's important to note that not all pharmacists and clinics will be able to get vaccine from this first batch. A new map is being posted today at www.manitoba.ca/vaccine that will show where all of those doses are going and which clinics and pharmacists will have some of them. It will also indicate which locations are taking appointments and which ones are not. We ask that only those who show us taking appointments are called. This is a new approach with a new vaccine, and we are still facing a limited supply. More is on the way in the weeks and months ahead, and so we will keep you posted with more information as we have it. With that, I will turn it over to Dr. Reimer to go into a bit more detail about the eligibility criteria for the AstraZeneca Covishield vaccine. Thank you so much.
Thank you. Good afternoon, everyone. I'm Dr. Jos Reimer, the medical lead for the Vaccine Implementation Task Force. So the task force has laid the groundwork for how we will deliver AstraZeneca or Covishield vaccine in partnership with doctors and pharmacists. And now that the vaccine has been approved for use and our first shipment has arrived, we will also provide guidance on how that vaccine should be used. This work has been underway for some time. Our clinical experts, and I'm one of the 30-plus physicians that provide advice on these matters from a large variety of different specialties, and also including some nurses and pharmacists, reviewed the guidance from the National Advisory Committee on Immunization, the clinical data, the local, national, and global epidemiology, and other evidence as well, to determine what the eligibility criteria would be for this vaccine for this first small shipment that we're receiving. So we have to recognize that the vaccine supplies are still very limited. And so we are treating each vaccine as a life-saving intervention. After considering all of these factors, individuals who are aged 50 to 64 and First Nations people aged 30 to 64 will be the first group eligible for this vaccine. We have developed a list of criteria to prioritize people from within this age group, and a person's doctor or pharmacist can make the determination if they should be considered a high priority. So the prioritization criteria are built on some of the examples that I've given in the past, but it's quite comprehensive. Nous avons créé une liste des critères pour établir l'ordre de priorité des membres de ce groupe d'âge. Les médecins et les pharmaciens peuvent également décider si une personne doit être vaccinée en priorité. Cette liste de critères est très complète et s'appuie sur certains des exemples que j'ai donnés dans le passé. So it does recognize that there are some people with high-risk conditions that are more likely to have serious outcomes related to COVID-19. And that's truly who we need to immunize as quickly as possible now that we're moving into this younger age group as recommended by NACI. Ces critères tiennent compte du fait que certaines personnes présentent des problèmes de santé qui augmentent considérablement le risque de souffrir d'une forme grave de la COVID-19. Ce sont vraiment ces gens-là que nous devons vacciner le plus rapidement possible. This list is going to be available on the vaccine website and has also been shared with our doctor and pharmacist partners. Our clinical advisory team believes that this reflects what we are seeing in Manitoba regarding who is at highest risk. We have developed a priority list 1 and a priority list 2, and we're recommending that people on priority list 1 be immunized first. So today I'm going to go through the priority list 1, but I do encourage anyone who has a health condition that they feel puts them at risk to check the complete list on our website and consider speaking to your healthcare provider if you're still not sure. I know that this list of conditions may be confusing for some Manitobans, but we do believe that creating this list is the right way to go to save lives and prevent people from ending up in the hospital. So priority 1 people who have chronic health conditions, including the following, will be included. Those who are receiving dialysis due to kidney failure, a very small list of severe liver conditions, that is cirrhosis or portal hypertension, a small list of severe heart conditions, that would include severe heart failure as an example. We also have a small list of severe lung conditions like cystic fibrosis, people who have a history of stroke where they have ongoing effects that impact their health after the stroke, People who have cancers that affect the blood, bone marrow, or lymph nodes, such as leukemia. People who have other cancerous tumors and are receiving treatment that affects the immune system, like chemotherapy. People who have a BMI greater than 40, which would define them in the severe obesity category. People who are taking medication that causes them to be significantly immunosuppressed, and we have a list of medications that we will be circulating to our providers. Having received or being on the list to receive an organ or a stem cell transplant. Having Down syndrome. And then those people who either do not have a spleen or their spleen does not function appropriately. We've also added to this list anyone who receives home care at least 4 times a week or is receiving 24/7 support from community living disability services. It also includes pregnant people who have another risk factor, such as being over the age of 35, having a BMI or body mass index over 30, or some pre-existing conditions like diabetes, high blood pressure, and some heart or lung diseases. I also want to flag that anyone who is currently eligible for Pfizer or Moderna vaccine, such as healthcare workers, and is between the ages of 18 and 64, would also be eligible for AstraZeneca or Covishield. However, I do want to clarify that if you have already received a Pfizer or Moderna dose, you should stick with the same product for the second dose and not go for an AstraZeneca. So the option for people who are already eligible is to go and receive AstraZeneca instead of Pfizer or Moderna if they find it more convenient to go to their healthcare provider or pharmacy. Clearly, there are many factors at play, many health conditions that we had to consider when we were developing these priority lists. We do plan to meet, I believe the plan is this evening, with the pharmacies and clinics that will be receiving the first allotment from this first small shipment of 18,000 doses, because we want to make sure that the prioritization and the next steps are clear for those providers. To help slow the spread of COVID-19 and protect the people around you, I strongly encourage all Manitobans to go and get the vaccine as soon as you are eligible. Call the call center if you're eligible through that mechanism. Or once we have the map listed, you can call the locations that are accepting appointments if you are eligible through this new list that we created today. So whichever vaccine is available to you, we strongly encourage you to go ahead with that vaccine. Even once we're vaccinated, we still need to continue to follow public health guidance, like wearing a mask, social distancing, and staying home when we're sick. As Dr. Rusin would say, we need to follow the fundamentals. And this is true for now, whether you've been immunized or you're still waiting your turn. We're still waiting for more science to help us understand whether or not people can transmit the virus after they've been immunized. And we're very early in the trials on that subject. But once we have more evidence, we'll be able to tailor some of our approaches in response to what we learn. So with that, we will open up to questions.
Thank you. A reminder to our reporters on the line, you will have one preliminary and one follow-up question. Up first this afternoon from CBC Manitoba, Bart.
Hi, Doctor. I'm going to switch here so I can ensure you hear me. I am receiving some reports of private acquisition by private firms of vaccine supplies. What is the province's position on that, of firms acquiring vaccines to administer their own employees?
So I'm not familiar with any cases of individual firms obtaining vaccine through alternate supplies. If it is occurring, my main concern would be whether or not they're receiving legitimate vaccine. Most of the manufacturers have very clear contracts in place with countries at the country level. And we have heard some reports of misleading offers of vaccine being offered to provinces, for example. And so while I don't know anything about the individual circumstances around private firms, I do want to ensure that whatever they're doing, that they are putting every effort into making sure they're providing a product that is effective and that is what it says it is. And certainly if they have questions about it, they can connect with us to make sure that they're not obtaining something that would be misleading to Manitobans.
Next question is for Johanu. Right now, we're still seeing some hiccups in the appointment process where we're doing, a couple thousand doses a day. How can you be confident that you will be able to book appointments for many more Manitobans once those larger vaccine supplies arrive?
Thanks for that, Bart. We've done tremendous work over the last couple of months to shore up the capacity at the call center. The recent hiccups at the call center had very little to do with the capacity there or even the volume of calls coming in. It had to do with a maintenance that was scheduled for after hours that happened to occur during hours. That's been addressed, and we will avoid that in the future. What will also help is our online booking system will come on, and taking sort of a further capacity into that stream to lessen anything coming into the call center.
From the Canadian Press, Steve.
Good afternoon. Just going through the list that has just been released about who's eligible for the AstraZeneca vaccine. It seems like quite a broad list with many categories. Given that we've received 18,000 this week, realistically, how soon should people on the priority 1 list, for example, how soon should they expect to be able to access this vaccine?
We know that there are more Manitobans in the priority list than there are doses available. So there's no question that the 18,000 doses will not reach everybody in the priority 1 list. So we are asking the docs and the pharmacists to identify within the people that they have access to the highest risk individuals, because they're in the best position to do that case-by-case medical assessment of somebody's risk. We are also asking that they do this very quickly. A large number of the vaccines in this shipment have a very short expiration date. And so we are talking to the clinics and the pharmacies and letting them know that these need to be administered in the next few weeks, and have gotten reassurance from a large number of them that they are well within the capacity to be able to deliver the unfortunately small number of doses that we are sending out to them. So Manitobans who are identified by the pharmacists or physicians can expect to hear from them likely next week, to be booked next week, the week after, but certainly in March. And what we're being told from the federal government is that future shipments could be coming as early as later in March, but we don't yet have any dates or quantities of those shipments when it comes to the non-mRNA, so in this case, the AstraZeneca Covishield vaccine.
And it's very logistically complicated to ensure the right number of vaccines are getting to the right pharmacies or medical clinics in different communities across the province. How do you do that while avoiding either wastage or severe shortages?
So I can feel that. The way we've been doing it is working very closely with our physician and pharmacist partners, for weeks now in preparation, and being very specific about how many doses they will get when, and then tracking those shipments as they go out. We're calling this a pilot phase of this model, precisely for the reason that we want to check every box along the way. So as those trays came in, we released them into our fridges. One of the first things that we did was reconfirm the doses that every single eligible pharmacy and clinic will expect, reconfirm the routes, double check, and then track them as they go out. So I guess in a nutshell to your question is very, very carefully.
From CTV Winnipeg, Michelle.
Hello, I want to ask about the decision-making around having the doctors and pharmacists doing their own booking. Why is this the best way to reach the people on these priority lists? And did the province consider doing this itself, so to make sure that we're getting everybody who has these conditions?
So I'll answer the first part and then over to Dr. Reimer on patient rosters. When we were first planning for this model, it became quite clear that there's a tremendous opportunity to use the flexibility and the capacity of the booking systems in place that pharmacists and doctors, some doctors' clinics have. Also, Manitobans are used to booking vaccines through their pharmacists and their physicians through the annual flu campaign. So it was a customer-centric approach, and it allowed us that kind of flexibility. In terms of patient rosters, I think I'll pivot to you, Dr. Reimer.
Sure. So, I mean, your question was, did the province consider contacting eligible Manitobans on our own? Simply put, we don't have the information to be able to do that. So the province does not maintain any databases that tell us who the different Manitobans are who have specific health conditions. Certainly there are some reportable conditions through the Public Health Act that we do have information about, but the vast majority of conditions, we would not have that information available. When we do our surveillance and epidemiology and our reporting, we have anonymous data. So we can say, approximately how many Manitobans have a certain condition, and we may even be able to say where in the province they live, or something like what age category they're in, but not who they are individually. Now that's different for a physician clinic. They have all of the information about the patients that come in through that clinic, and particularly if they have an electronic medical record, they can search by condition in their record, and so would be able to pull out a list of individuals who would be eligible based on this priority criteria. So, as much as it might have simplified the identification of Manitobans, it's just not something that our government or any government maintains as far as information about their citizens.
Okay, thanks. Also wondering, because this is a pilot phase, what are some challenges that you're maybe expecting or kind of have your eye on?
Well, certainly we are watching how well it works for us to publicize the locations and of these clinics and pharmacists without having them be overwhelmed. And hence why we have this map that will be published later on today. And Manitobans will see that some clinics and pharmacists are green and some clinics and pharmacists are red. And we're really asking that, A, don't call if you're not eligible, but B, don't call if a clinic or pharmacist has flagged themselves as red. There's a reason they've done that. It might be because they already have their own patients identified through their roster, and so their vaccine is tagged, if you will, or they might be done with supply. 18,000 doses is not a lot to distribute throughout the entire province. In fact, we're looking at a range of between 50 doses to 200 doses, with some exceptions in the city going out to each of these clinics and pharmacists. So it's not like there are tons of appointments at this time. So that's something we're certainly watching. Doctors and pharmacists have been tremendously collaborative in us doing this together, and we would not want them to be overwhelmed by calls.
Well, one of the challenges, which is both an advantage and a disadvantage to this process, is the flexibility that it gives and the autonomy that it gives to individual practitioners to identify who is highest risk because they know individual information about that person, more than just a category of health condition. So the benefit is certainly that they can tailor this to really target those individuals who we're concerned about could end up in the hospital. The disadvantage is it does mean that we're going to have less consistency. So certainly there's going to be a variety of approaches from each provider. And as much as we provide guidance, they are private businesses. We don't control everything that they do in their clinic. So we do expect that there's going to be individuals and stories that show that one location does things differently than a different location. And that's going to be frustrating for some Manitobans, absolutely. But the flexibility and the benefit for Manitobans to be able to meet with their trusted healthcare provider, have that conversation, and to have an individual assessment just really outweighs the potential inconsistency that we might see in the rollout. So this is an excellent addition to the super sites, and we think that both are incredibly valuable for different reasons.
From City News, Jonas.
Good afternoon, folks. Dr. Reimer, just wanted to maybe get you to expand, I guess, on some of the discussions over how this list of Priority List 1, Priority List 2 was reached, and I guess just maybe what are some of the outcomes and I guess some of the things that COVID can impact that required these folks to be on Priority List 1?
Sure. So we started by looking at guidance at the national level, also from the Centre for Disease Control in the States, and from the UK advisory bodies as well, to see what conditions they were flagging were the highest risk for severe outcomes like hospitalization or death related to COVID-19. We then also looked at the Manitoba-specific data that we have collected in our case and contact investigation to determine which health conditions were appearing most frequently in those people who ended up in the hospital or who ended up dying. We compared that then as well to broader data from Canada and other countries as well, to make sure that because we're a small province, that we weren't by chance, because we have a smaller population, missing health conditions that have been shown to be high risk in other locations. We then took that to our medical advisory table, which, as I mentioned, has a large number of physicians from a large number of specialties like immunology, infectious diseases, oncology, obstetrics, and many others, as well as pharmacists and nurses, and had them assess it based on their medical expertise, what they're seeing with their local patient populations. And they also were able to delve deeper into the more specific literature and evidence around each condition that we wouldn't be able to do at the provincial level in the same depth. And so that committee together went through the whole list and discussed some of the pros and cons, how well we could define different conditions to create this final list that we believe truly represents the highest risk people in the younger age category. And so we are open to shifting it as things go forward. I'm certainly hopeful that as our supplies increase, that we won't have to continue to identify people by health condition, that this will be a temporary way that we use this small number of doses to target people in the short term, but that once we get big supplies coming in of AstraZeneca, that we'll be able to open it up much broader than just having a list of conditions that we realize is going to be confusing for some Manitobans to see themselves in.
Thank you so much for that, Doctor. Mr. Botha, just this morning we got an update on both Pfizer and Moderna shipments double from what we've been receiving previously. If you don't mind, sir, maybe just an update on what Manitobans can expect to see from Pfizer and Moderna.
Sure. So I think in a nutshell, what we're expecting, it has doubled, and what we expect to administer with those is now about 120,000 doses from now, looking 28 days ahead. So between now and 28 days from now, 120 doses, which is close to double of what we were expecting only a couple of weeks ago. And this goes through our super sites. It includes what's coming up on our pop-up models next week, and then as well as our focused immunization teams. So we are going to be able to pump out more, almost double than we were expecting, and the system is ready and is doing that. I should add that there is this noted discrepancy between the amount of doses coming in and that 120,000 figure. That isn't because we aren't using things. We are trying to drive our fridges down to zero every week before the next shipment arrives. That discrepancy is simply there because there are obviously thousands of doses coming in that go to our First Nation partners.
From CHVN, Taylor.
Hi, good afternoon. How is the province looking to speed up those appointment booking wait times, especially since we are starting to near a population who may not have an hour to wait for a call back?
So thank you. Yeah, we had some issues at the call center yesterday, not to do with volume as I had mentioned, but because of a maintenance that was that occurred at an incorrect time. And today we're back at waiting for minutes. So hopefully that is what we'll continue to see, and that's what we expect to see.
And the first case of COVID was discovered in Manitoba a year ago this week. Dr. Reimer, how are you feeling about our vaccination rollout since then?
Yeah, I mean, in some ways it feels like it's been a lot more than a year, and in some ways I can't believe that we're already at a year since the first case. It's been a bit of a blur, I think, for most of us in public health who haven't had much of a chance to take a breath in the last year. But I think I have been pleasantly surprised at how quickly vaccines became available. We've never seen the whole world come together to work so efficiently at creating a new vaccine like we have in this case. If you would have asked me in the fall when I thought a vaccine would be ready, I would not have said December. I would have thought it would have been into 2021. So, it's been really exciting to be part of the light at the end of the tunnel and play a small role in getting Manitoba back to at least some version of normal. And to watch this amazing team that we have here in Manitoba create a system of vaccine rollout like none we've ever had before. The highest number of doses we've ever given out in a vaccine campaign before was H1N1 in 2009 and 2010, where we almost reached 700,000 doses. And now we're talking about millions of doses. And so we've set up brand new super sites. We've set up pop-up clinics and these tailored fit teams. And so, I think most of us on the task force are eager to get going even more than we are. I think we can't wait to get more doses to start to get them to Manitobans as quickly as possible and get this year behind us as quickly as possible as well, and maybe start to feel a bit more normal as we go into the summer.
Thank you.
From the Winnipeg Free Press, Danielle.
Hi, and good afternoon. Dr. Reimer, you were talking about inconsistencies in how pharmacists and doctors might administer the doses they receive. Are you suggesting that physicians and pharmacists have authority to depart from the guidance you've provided today, or what are you anticipating?
So we have created guidance to do just that, to guide our physician and pharmacist partners in who they should be prioritizing based on the science, based on the local epidemiology, as well as the global information that we have available. But every physician and every pharmacist is going to have a different patient population that they serve. So some of them will have some people who are on dialysis, for example. They may have a lot of patients on dialysis, whereas others might be more focused on people who are pregnant. So by the nature of rolling out to a large number of partners throughout Manitoba with a variety of geographies, a variety of patient populations, a variety of healthcare needs, there will be differences in how they target those populations. And for the most part, we see that as a strength of this, in that they can do those individual tailored assessments and targeted approaches to what their community needs. But some of the downsides to any sort of broadly spread out distributed model is that you may see differences in between how they interpret things and how they apply it. So certainly we're not saying that they can deviate from the priority lists. That's not the intent at all. Rather, it's a recognition that Manitoba has a lot of different populations, and even within the same populations, different providers who work in different areas of health, different body systems, for example. So we will see some variation, which is both an advantage and sometimes a disadvantage.
Thanks very much for that clarification. I was also hoping maybe you could provide a little bit more information about the future of the distributive model. So while we don't have confirmed AstraZeneca delivery schedules, based on what the federal government has told you about the forecast for deliveries, by what date do you think we could fully flex the capacity of physicians and pharmacists?
I can take that one. So, as Dr. Reimer had said, we are expecting some as early as the end of March. And certainly over time, we're talking about tens of thousands or hundreds of thousands of doses. And then there's other vaccines that may be approved that is also easy to distribute and don't have the same cold storage requirements that could leverage this model as well. So the hard timeline is we'll have to wait to see when the federal government confirms it. But we can see that we will probably get into a scenario in Q2 where this distributed model, using all the lessons we learned during the pilot phase, can easily do between 5,000 to 10,000 doses a day.
From Global News, Brittany.
Good afternoon, Dr. Reimer. I'm wondering if you could just clarify a few things for us and really make it so people can understand. On this priority list that we have right now, and with 18,000 doses coming in, if you are on that priority list, will you need to wait for a doctor's office to call you saying that you've been determined to be in that high-risk group, or can you make that call to a pharmacist or doctor to book because you have that condition? And if it is a pharmacist, are you going to need to prove that you have that condition through some sort of verification from a doctor, say like a note or something?
I think I can take that and you can add on if you want to. So we, as we mentioned, we've created a map system that's going to show all of the clinics and pharmacies that have been sent doses. But we have asked them all individually to make themselves marked as either taking appointments, so phone calls, or that they're not, which might mean that they are reaching out individually to their patients, or it may mean that they have already used up all of the doses that were sent to them, because some of them are getting, as little as 50 doses, so that may very quickly be used up. So certainly we're hoping that in many cases people will be reached by their clinicians if they truly meet the priority 1 conditions. But there will be facilities, clinics or pharmacies on our map that are labeled as green or accepting calls. And if Manitobans look at the list and see themselves reflected in that list, they can call any of the ones that are labeled as accepting phone calls and discuss with them booking an appointment. In regards to proving a health condition, the pharmacists and the physicians are medical experts. They have a lot of training in doing clinical assessments, and so we have a lot of trust that they'll be able to do individual clinical assessments of the person who comes in to determine whether or not they meet the eligibility criteria. We're not setting up an official system where they would need to come in with some sort of a note to prove they have a condition, no more than we would expect them to come up with any sort of explanation as to why they would need to be seen by a physiotherapist, for example. We really do trust that medical assessment by the clinician is being done in a way that reflects that person's health status.
And my second question is on the dose delay that we're seeing, or we're doing here now, pushing to the 4 months. We've heard from some doctors that are coming out in Ontario saying that they've got concerns over that, and Pfizer says they weren't consulted. Since we started doing this now, do you have any other concerns of your own with pushing this to 4 months, and how do you address doctors that are saying that it's dangerous?
So we have looked at data from BC, Manitoba, Quebec, the UK, and Israel in regards to the safety and effectiveness of the first dose and delaying the second dose. So what we saw in pretty consistently throughout every trial that was run was that all of them showed, and they were using them in very high-risk populations, all of them showed in the 70s or in the 80s as far as effectiveness to protect against infection. And for real-world effectiveness from a vaccine, those are very high numbers. So we were really happy to see how effective that first dose truly was, and that effectiveness remained throughout the study period. Obviously, we haven't had the vaccines around for 4 months, But we did have some of those trials going up to 2 months and didn't see any decrease in the effectiveness at that point. And we know that immune status doesn't change overnight. So even if we did start to see a decrease after 2 months, it wouldn't suddenly drop. And we certainly would have that opportunity to continue to reassess in that 3rd month and ensure that what we're seeing continues to be the best option for Manitobans. So when we look at vaccinology more broadly, most of the time the concern around the first dose is how well does it protect on its own. And once we know that on its own it's quite protective, the second dose is what we typically consider a booster. And the booster's main role is generally to prolong how long the protection lasts, more than it is to increase the amount of protection, though that certainly occurs as well. And so the second dose is still going to be very important for Manitobans to make sure that that immunity remains long-term. Because we certainly don't, in the fall, want to have a repeat of this year where we're seeing outbreaks where we have to start shutting things down. So we have every intention of continuing with the second dose unless we suddenly saw something in the literature that showed us a different path made more sense. And we feel quite confident in what we're seeing in the science from these studies, that they really parallel what we've seen from other vaccines. And so taking all of that together has led us and pretty much every other province to feel comfortable that this is the best option. But we do recognize that we're all learning together. This is a pandemic, and so the whole world is gathering information at the same time on a new virus and on a new vaccine. And so we will be watching and continually reassessing our approach to make sure that we are using the best information that we have while we have it.
From the Brandon Sun, Michelle.
Good afternoon, Dr. Reimer. Following up on the previous question, I was going to ask about that myself. I'm wondering, considering we're only at the 3-month mark since the first vaccine was administered, could there be repercussions for the province if this experiment, as some people are calling it, fails?
So, I wouldn't say that this is an experiment any more than anything else is in a pandemic. This is a virus that we've never faced before. These are vaccines we haven't used before. So everything we're doing for the first time. And the whole world is doing this at the same time. So we have some information from other jurisdictions that might have a few months more data than we do. And so we're using as much information as we possibly can to make the best decisions we can. When we have a limited supply, it's really important that now that we know that first dose does provide that 70 to 80 plus percent protection, it's really important that we get that available for as many Manitobans as we can as quickly as possible so that we can move towards what we call herd immunity. And by herd immunity, I mean that we start to protect each other because once we are not able to carry the virus, we then can't spread it to others. And early studies seem to show that there is substantial decrease in the ability to spread the virus to others, although we're still early in the science. So I think that no matter what course we take, we have to be ready to change course if we see something in other jurisdictions or in Manitoba that shows that there's a better approach. But I feel confident that this decision is going to protect more Manitobans than if we continued with sticking to that second dose schedule at the 3 or 4 week mark, meaning that we would have half as many Manitobans who are protected at any given time.
Okay, thank you. My second question is for a reader. She's an elderly woman, 80 and over, and it's related to booking appointments. So it was announced the other day that if you fit into the category 80 and over, you can book your own appointment and, for yourself and for others. Now, in this particular case, she lives on her own, and a couple has been looking after her who are also over 80. But despite being told at some point that she could book appointments for the three of them so they could go together because she's not able to go by herself, when she did try to book, it wasn't possible. So I'm just wondering to clarify for the elderly, does it have to be same household in terms of booking more than one appointment?
I can't speak to that particular case. We do now allow people to book for someone else, not necessarily same household. I think that's all I have on that one.
From CJOB, Anya.
Good afternoon. Right now it seems like we don't have a lot of trial information for the vaccine being used on people who are pregnant. So what made you put them on the list without that extensive research? And do we know more right now? Is there an impact to the baby or any other side effects that differ from people who aren't pregnant?
Oh, that's a great question. Pregnant people are excluded from almost every trial that gets run unless it's specifically about pregnancy. And so we often in clinical practice have to function with very little trial data to fall back on, and end up needing to use the information that we have from the non-pregnant population and apply that to the pregnant population. And then look over time to see whether in the real world the benefits outweigh the risks. So that's true for almost every medication that we offer in pregnancy, almost every vaccine that we offer in pregnancy, those folks are typically left out of trials. So this really isn't any different than any other time that we're applying a medication or any sort of treatment or intervention that isn't pregnancy specific for pregnant people. But what we've seen so far in those who were included in the trials, because there were some individuals who became pregnant during the trials or were found to be pregnant despite the eligibility criteria, they did not have any negative outcomes related to the vaccine. While what we have seen is that certainly related to the virus itself, there are negative outcomes. And we're seeing more that pregnancy and some of the health conditions when people have them on top of the pregnancy are putting people at risk related to the virus. So we did this in consultation with several of the obstetricians that sit on our medical advisory table, and they reviewed the literature more broadly. They looked at the advice from the Society of Obstetricians and Gynecologists of Canada, the American equivalent, as well as the UK equivalent of that body, to assess what their guidance was. And the Society of Obstetricians and Gynecologists of Canada, really is advising that there's no clear concerns about providing the vaccine in pregnancy and no evidence of harm relating to breastfeeding either. And so they are recommending that, where, for example, somebody might be a healthcare worker and be at high risk of being exposed to COVID, that we should be strongly considering that the vaccine's unknowns are less significant than the known risks associated with the infection. So we don't take this lightly. And unfortunately, in this area of medicine, we're used to functioning with less evidence. But there was nothing in any of the trials that showed any negative outcomes for the baby, for the person who's pregnant, and similarly, nothing that demonstrated any harm related to breastfeeding. But as always, and in particular when it comes to pregnancy, we monitor as we move along, and as soon as we see any flags of concern, we can pull back and reassess.
Okay, great, thanks. And how are you guys prioritizing, or how did you decide which pharmacy locations will receive vaccine doses, and are some receiving more doses than others?
Thank you for that. Yeah, so the process that we used was we looked at those that had made it through a registration process, so they were ready to receive vaccine. That's sort of step one. Step two were those who were already through the process before the federal government approved AstraZeneca. We needed to draw the line somewhere because the shipment was so low. And we don't want to necessarily ship out 1 or 2 doses here and there. That's not efficient. So we had that first group, if you will, and they were around 300 there were around 350 that were eligible, and then within that line was 191. So we worked directly with 191 to see how much they could do and whether or not they fit our population distribution, because we certainly want to distribute these across the province in a way that matches our population. And so we landed on a figure ranging between 50 and 200 doses. There are some exceptions in the city. So that's how we did it this time. We guided by population, the readiness and the willingness of the clinic.
From the Winnipeg Sun, Scott.
Hi, good afternoon to both of you. And I apologize if this has been asked, but I can't recall if it has or not. But do you have an estimated population of people in these age ranges for Priority 1 and Priority 2 lists?
So yes, we actually do have that, although I don't have it in front of me right now. So I would have to go back to our surveillance team to see what they might be able to provide more publicly. But we did use estimates to inform the decision making. And, as I mentioned, there are certainly more than 18,000 people who would be eligible under the Priority 1 conditions in that age group. So we do recognize that even with what we tried to be as narrow as possible with our high-risk conditions, that there's still, with such a low number of doses, wouldn't be able to reach everybody in that priority group. But we did want to make sure that we included all of the conditions that were really being flagged as high risk, so that there was a little bit of flexibility, because we know that, as I mentioned before, different communities will have different amounts of different health conditions, and different clinics and pharmacies may provide services differently in a way that certain health conditions might be more prevalent in those settings. So I'll take it away to the surveillance team to see if they can provide any estimates, but we do have that, yes.
Thank you. And on the website, it says anyone who is already eligible for the Pfizer Moderna vaccine, such as healthcare workers, and is within 18 to 64 age range, is also eligible for the AstraZeneca one. But I guess if people were to read that, that would also suggest that just people 80 and over and 60 and over through First Nations are also eligible. Is that misleading with what that says, or is it just priority list 1, 2, and then those folks that would fall into the Pfizer Moderna part as well?
So what we've done is said that anyone who is already eligible for Pfizer or Moderna because of that provincial eligibility criteria and is between the ages of 18 and 64 could also be eligible for AstraZeneca or Covishield if they would prefer to receive that vaccine, either because of something related to allergy or convenience of getting it, or they want to have that conversation with their healthcare provider. So the intent there is really just to, where we're able to provide flexibility so that people have the best chance at accessing what they're already eligible for, recognizing that NACI has recommended against going above age 65. And knowing that, as people choose one vaccine or the other, that doesn't really decrease the supply overall. So if we had, a whole bunch of healthcare providers elect to move to AstraZeneca, it would just mean we can move down in ages that much faster with the mRNA vaccines and vice versa if those healthcare providers were more likely to choose the mRNA settings because the super site's more convenient for them. We would have that many more doses that we can use for people with these high-risk health conditions in the younger age group. But the goal really is to help Manitobans have facilitated access to vaccine because we want as many needles going into as many arms as quickly as possible.
Our final reporter this afternoon from CBC Radio Canada, Matthew.
Hi, good afternoon. When pharmacies and clinics will officially be allowed to administer vaccine to people?
Thanks, Matthew. I think the question was when they will be allowed to administer vaccines to people. That's the question that I heard. But starting tomorrow, we will have started to ship these out all across the province at around 191 locations. Obviously, it's a large, geographically complicated province, so they'll arrive over a period of days, and then the moment that either clinics have reached out to their patients or the pharmacist gets their first booking done, they can start. I'm anticipating the first dose to maybe as early as this weekend, but probably early next week to be in. Did that answer your question, Matthew, or did I mishear?
Yeah. And will French language services be offered in pop-up clinics, for example, in Saint Laurent on March 25?
That is a really good question. I would like to say yes, but I will have to follow up, and we'll take it back to the team.
Thank you.
Thanks, everyone. This concludes our media briefing.